Well, good morning or good afternoon, everyone. It's great to see everyone. It's been a while since we hadn't met in March. Hopefully, many of you had an opportunity to attend the forum, the Maternal Mental Health Forum in March, and we'll do a roundtable on the forum at the end of today's call. We're excited to welcome you to meeting number 9. I can't believe it. April 17th, 2024. And we're going to talk today with 2 state public health departments about how they're leading efforts on maternal mental health. And they've really, I think it's safe to say, been the 2 public health departments in the country that have led this movement, starting with Massachusetts and Beth Buxton, who I'll introduce in just a moment, and then our colleagues in Colorado. So we're so thrilled to welcome them back to our Fellows Program. They've been presenting with us, I think it's the 4th year, perhaps the 3rd year. Many conversations and dialogues with these partners over the years. So we're thrilled to have you back. Thank you, Beth, Mandy, and Jessica. And Melissa, good to see you from March of Dimes and others, our fellows. If you can do what Melissa did and add your organization name to your name in Zoom if you haven't done that yet, and ideally the state that you're in so that our partners from Colorado, Massachusetts have their bearings a bit, that would be fabulous. And we can go ahead and advance to the next slide while everyone's doing that. Thanks, Stacy. Just wanted to thank Sage Therapeutics again for their work sponsoring the Fellows programs. And briefly, we wanted to remind you all what we talked about in February. It's been a little while. You might remember we had our partners from the CDC join us to talk about PRAMS, the Pregnancy Risk Assessment program, which most of our states here engage in around the maternal mental health questions and outcomes. We were grateful to see that anxiety is now being addressed through PRAMS, not just depression, so some really great work happening there. And you each had an opportunity to pull your own state PRAMS data if you participate. Again, most states do. We also address screening for maternal mental health disorders. If you need a refresher on all that we discussed, all of these materials are in the Google Drive for you to access. What are the validated tools? What are the recommendations for screening, including a recap of the Alliance for Innovation in Maternal Health. That's the federal program through HRSA and the recommendations there that the state perinatal quality collaboratives will be working with all of you in partnership to lead implementation around. So really important that you're up to speed as you work on your action plans and work in your own states and programs around screening to know what is happening, the latest developments there. We also talked about workforce development and network adequacy. So we know there are shortages of maternal mental health providers, reproductive psychiatrists, even obstetric care providers for that matter, and shared some of our network adequacy standards on how we're supporting all of you in growing the workforce and measuring whether there are adequate networks within Medicaid provider networks and also commercial provider networks. We talked about Arizona being the first Medicaid program that's going to start monitoring for the number of PMHCs, perinatal mental health certified providers in their networks. And Beth, I see you nodding, and Colorado, be great to talk about some of this. And then public awareness campaigns, because we wanted you to have an opportunity to prepare for May next month as Maternal Mental Health Awareness Month. We can talk a little bit more about that during our roundtable to make sure everyone's ready to be engaged in some way in the next few weeks. All right, Stace, we can move to the next slide. Our agenda for today, besides the recap, is we're first going to get to hear from Beth Buxton from Massachusetts, and then our 2 colleagues from Colorado. We'll have time to unpack and discuss with them, which we're really excited about this conversation. And then we'll do some feedback and talk about the forum, and then get ready to think about graduation in end of May, I think it is, and also just finalizing your action plans. Or fine tuning, since they're always a work in progress, right? Stace, next slide. Now I get to introduce Beth Buxton, who I think it's safe to say is an icon in the space of maternal mental health and certainly a hero to me. Beth has over 20 years of experience in community and public health work, and her work now in Massachusetts focused on policy and programming in the maternal child health division in Massachusetts. She's responsible for many things, including early intervention efforts and the maternal mortality review efforts in the state of Massachusetts. She also works on pregnancy-associated deaths and reporting of major findings through that scope of MMRC work. She coordinates all of the perinatal mental health or maternal mental health initiatives. I think it's safe to say all, Beth. I added that. It's not in your bio. And works with the Massachusetts Postpartum Depression Commission, which was created through a legislative initiative, which I know she'll tell us about. And that commission helps pilot programs, doing a lot of work around data collection, which is where the rubber meets the road. I can't wait to hear more about that. And Beth has received several awards, and we're so thrilled that she's here. Beth, I'm going to end there. Welcome back. It's great to see you. And Beth's going to
Thank you so much, Joy. I appreciate it. Hello, everyone. I am going to share my screen now, and we are going to hope that it works. Let's see. And please let me know if you can't see the screen.
We can see it.
Oh, perfect.
You might put it in slideshow if that's not too hard for you. There you go.
Yep, that's perfect. What I'm going to do now.
Even
Thank you.
Thank you.
So what I'd like to do is provide a brief presentation of the work we've been doing over the last 20 years. No, 15, 20 years around perinatal mental health in Massachusetts. So give you some background, talk to you a little bit about the data, talk about a little bit of what's worked for us in moving the needle and making concrete changes in the state, and then also thinking about the resources and some other things that we're keeping an eye on right now. So one of the first tools I'd like to share with you, and feel free to do this as well, is one of the things that, one, I'm a perinatal social worker by training, and so I know that relationships are really key to all the work that we do. And in order for us to start thinking about perinatal mental health in a broader sense, we really needed to start building stronger relationships with each other, because there's so much stigma associated with perinatal mental health. There is, we're dealing with a lot of institutional and structural racism that impacts a person's mental health and their ability to access resources. And it can be, a lot of people have lived experience with it as well, so it can be triggering. And so in order for us to really support each other and to build strong relationships, one of the things that we do are these introductions, and a way of just sharing who we are. We share our identity. I will always share my pronouns. I will share that I identify as white and Italian and Irish. And then I also share that, my lived experience includes a parent with 2 major mental health disorders, and I've also personally experienced homelessness. And so being able to build those relationships and then also have a little fun with, on a scale of cats, how do you feel today? People are really able to engage in different ways, and we can support each other. So if one of my friends, says to me, I'm a 9 today, I got nothing, I am like exhausted, that's a way, a notice for me to say, you know what, I'm going to be here to support you in this, and we're not going to assign you any tasks, and we just want you to try to be as present as possible, but also take care of yourselves. We have to really model taking care of each other. So this is just a little fun way of me doing that when we're talking about some really tough topics. So this is some of the background. Back in 2010, and I will say, in 2010, an act relative to postpartum depression was enacted. There is about 5 years of prep work before this act was actually adopted. A lot of advocates came together to work together. And part of it was we passed regulations that require healthcare providers and health plans, the carriers, to report their screening data to DPH on a regular basis. And so I put a link. You're gonna get all of these slides, so you can check this information out yourself. But what we did was we worked with our health plans and our health providers to say, okay, this is a requirement. You need to report your data. We need it to get a better understanding of the landscape out in the state. What's going to be the easiest and most effective way to do this? And it literally took us 2 years of partnering with health plans and healthcare providers to identify a claims code. And so you'll see here the claims code with the diagnostic range and the modifiers. And me and my colleagues went literally on, a tour across the state, visiting with all the health plans to gain their buy-in to this. And they did. They completely bought in, and they agreed to reconfigure their systems to accept this claims code that would then send this data onto the Center for Health Information Analysis. And we've been able to access that data since 2016 and been doing some analysis and annual reporting that's available on our website. The other thing we did is we worked very closely with our Medicaid program. We call it Mass Health here in Massachusetts. And so they agreed not only to accept this claims code, but they also agreed that they're going to pay providers to do the screening using that claims code. And that's not just obstetric providers, includes pediatricians and primary care providers and family care physicians. And so we came up with a screening tool grid that both state agencies agreed to. And these are the tools that people can utilize to screen, and Mass Health will pay. And at the same time you're getting paid, you're reporting your data to DPH under the regulation. So it really streamlines and supports providers to make it easier. So what is the data telling us? As you can tell from my pictures, I do love cats. And so unfortunately, it's not telling us what we need to know. From the data from the PPD screening regulations, that you do the screen, you use the claims code, you send it to the insurance company sends it to the all payer claims data system that we then get access to. According to that process, only about 16% of eligible individuals are actually getting screened in Massachusetts, and that was in 2020. And of that, about just under 14% had a positive screen. So somewhere along the line in that process of claims code, things are breaking down. And because I really believe that more people are getting screened than just 16%, particularly in Massachusetts. So we're working to figure out where that breakdown is so that we can then intervene. But what we do know is that its rates of postpartum depression were higher among Asian and American Indian compared to others. And that the positive proportion was higher among women who were covered by Medicaid. I'm sure you're not surprised by that. And the percent of positive screenings decreased as the woman's educational level increased. We also looked at PRAMS, which I know Joy just mentioned, the Pregnancy Risk Assessment Monitoring System. This tells us a very different story. This is saying that compared to white non-Hispanic mothers, it's Black non-Hispanic mothers and Asians who are more likely to experience symptoms. And it's similar in the education, more likely with a high school education to have a higher prevalence of symptoms. But there's clear racial inequities in our data, where Hispanic mothers are getting screened far less often than white non-Hispanic mothers. And I think for me, this is the most telling data from the PRAMS. And again, this is 2021. If you look at this data, you're looking at probably 37% of individuals who gave birth experiencing some level of depressive symptoms in the state in any given year. That's a huge number, and it's pretty profound for us. So what are some of the things we're monitoring right now? Some of the big things that are on our table that we're keeping an eye out on. One is the new FDA-approved medications. And as exciting as they are, I know that although they got to come up with better names, I'm still trying to figure out how to say these names. The
I
IV
agree.
drip,
And we learned that it's not the drug company, like it's some other FDA process. Isn't that
is
interesting?
it?
Why would they name it like Zeus names? That's like so masculine and not.
Right, right. Totally agree. But with Zulresso, which is the IV drip, which is highly expensive, we've learned in Massachusetts after doing assessment, there is not one hospital system that would agree to provide this to any Massachusetts residents. The closest one we have is Women and Infants Hospital in Rhode Island, south of us. And what we heard on the side are people just saying they question the validity and the effectiveness of this medication. And so we need to take a step back with our clinicians and see where we can work with them around these new medications. The one with the pill, which everyone is really excited about, the daily pill, 14 days, again, the price and the cost are expensive. Some of the concerns with that we're keeping an eye on with the health plans is that we're worried that the health plans will require patients to first go through what they call a failed trial of SSRIs. And I worry, particularly with parents with so much going on in their lives, from childcare to work to everything, that we're going to lose them and they're going to drop out of engaging in treatment because there's so many other things going on in their lives. I will say, with our work with our Medicaid program, Medicaid has stated that they will pay for both of these without a doubt, whether it's in Rhode Island for the drip or the pill here in Massachusetts. The other thing we're keeping an eye on, and I'm really keeping an eye on it because I'm managing this whole thing, so I'm definitely keeping an eye on it, is we came across federal money that we're able to use to provide grants to providers across the state. And specifically, access, infrastructure, and workforce development. So usually what we've done in our procurements is said, okay, we have this program, these are the strategies, these are the outcome measures we're looking for, this is the data we're expecting you to collect. Respond to this RFR, this request for funds, if you're interested, but this is how it's going to look. Instead, what we're really trying to think differently about and engaging in the community and letting things be, supporting the community leading it, is saying, okay, you tell us what you need. It's a little scary for the community because they kept looking at me in our bidders conference going, what, you're really going to let us decide? I'm like, yeah, I really want you to decide what's going to work. You know your community, I don't. So what's going to work best for you? And some of them are coming in with saying, we want to build a birth center. I'm like, let's do it. We had one hospital system says we want to do an intensive or a partial hospitalization treatment program for pregnant and parenting individuals. I'm like, complete the application, send it to us. A lot of people, our workforce is completely either burnt out or diminished. Really looking to how we can recruit and hire and diversify our workforce across the spectrum. So what's happening now is the request for responses is out in our community. It's due back May 1st, and hopefully I will know what exciting new projects we will be implementing come July 1st this year. So this is something I'm really excited about. So when I think about resources and supports, one of the things, I'm going to try to do this, Joy, I hope it's okay, is just show, this is a very short, like 2-minute video, but I think it would be really helpful if I could figure out how to stop sharing. End slideshow. New share. It's not working, is it? Of course. Stop sharing. There we go. All right.
And Beth, when you go to share it again,
Yeah.
however you're going to do that, there's 2 little boxes at the bottom. They'll say, all right, so make sure those are checked and we should be able to hear
I
it.
did do that. Thank you. All right. Wish me luck. Hoping this works.
My name is Douglas. I grew up in El Salvador during a time of civil war. When I was 5 years old, my father was captured and suspected to be murdered. He disappeared from our life. When I found out that my wife was pregnant with our second child, I was so happy to hear that we were having a boy. I couldn't wait to be the father to a son that the way that my dad didn't have a chance to. I pictured teaching my son to drive, teaching him what I learned in life, and being his friend. By 15 months old, my son's behavior and development was causing a lot of stress in our family. I was devastated to think that my dreams for us wouldn't come true. He couldn't play with me like I had expected. I felt like I couldn't make him happy. He only wants to be with mom. I felt left out and I didn't know how to help him. At the same time, I couldn't find work. I felt like a failure. I couldn't provide for my family. My wife always see me disappointed, and I felt like I wasn't a good dad. I figured maybe I would just disappear too. Because our son delays, our family started receiving services from early intervention. Their work was surprisingly personal. It was not just therapy for our son. They saw us a family and wanted to see us a better place, happier and healthier as a family. As we learned to be the best ways to communicate with our son, I started to feel connected to him. He started to smile and laugh with me when our workers gave us ideas for games and activities he might like. He's even starting to learn a few words now. I come home from work and he runs to the door, saying Papa and hugs me. Now my kids fight over who gets to sit next to me. I feel like a dad. I heard that couples with children with special needs separate more often. This doesn't surprise me. The intervention that we are receiving help to pull us from some of the darkest stages of our life. I don't feel anymore like I want to disappear. My wife and I are learning how to communicate better and appreciate each other. We are acting like newlyweds now instead to be a stranger living in the same house. Most importantly, I feel hope that my kids will have something special that I have to offer them as their dad, a friend, a teacher, a coach, a role model, and a guide.
That's great, Beth.
Now, just end it. Um, I'm glad that actually worked out well. What do people think about that video? Any initial thoughts?
Don't be shy, everyone. Let's hear ya. I mean, Beth, I'll say while we're waiting for others to feel comfortable, I know your
Yeah.
background's in early intervention, but number one, of course, families with children that have special needs need all the support, as much support as we can give them. And it also makes me think about, do all parents really need some sort of support like this in the postpartum and early parenting years? Those are my reflections, but that was so great to see. Thank you.
Right. Yeah, for me in this work, one of the things I've learned pretty quickly is it's parents' stories that have the most impact on legislators, policymakers. And so fortunately, we're able to have some money to do these digital stories and be able to share them. They're on our website. Anyone can use them. But what made it even more powerful for us, I don't know if you heard, Douglas stated that he wanted to disappear. He was suicidal. And his wife did not even know that. And so we were grateful that we had the social workers there to support them. And both of them are now advocates, just outside of Boston, and talking to other parents about their experiences. And they're the ones that are showing up at, legislative events and public awareness days. They have far more power than I could ever do. It is really them. And so being able to find and tap into that type of expertise and just that vulnerability and grace to share, I love Douglas, by the way. He's awesome. And his wife, Maria, is awesome too.
That's awesome. So, I mean, I'm definitely hearing, and I think probably many of us have seen this in action, but your words just solidified it that, when someone's invited to tell their story, they become an ambassador in more than one way, right? To effectuate change. And that was incredibly powerful. I have another question for you about the story while we wait for others to hopefully answer or ask some questions and give some thoughts. What program identified, it sounds like it was an early intervention program, but was there some sort of screening or something related to paternal mental health that happened there too, Beth? Or there doesn't have to be. I was just curious if there was.
No, you're absolutely right. One of the things that I do is go and conduct trainings at a lot of community-based organizations. I was doing that for a while. And so for that agency, I had done training, and they decided to adopt universal screening because of the training. And so that's how they were able to identify the families. And then when we were able to get additional funding, the families in the program was all over being able to share their stories and to celebrate them.
That's great. So community-based organization versus provider screening, which seems to really, the story sort of fits that. It was the father and high needs family. That's great.
Absolutely.
Not a clinical setting with the mother, right?
Right. Yep. And it worked. That, especially when you're a home visitor, you really get to build trusting relationships over time, and it makes it a little bit easier to do the screening and to share and be vulnerable. Great. All right, my quiet crew. I will wait until the end.
No, come on, you guys.
It's okay.
Everyone. Okay. Well, we'll wait. We'll keep going, Beth. Thank you.
It's all good. So as Joy had mentioned, that same legislation back in 2010 established the Ellen Story Postpartum Depression Legislative Commission. It's called Ellen Story because she was the House representative that really spearheaded the initiation of it. It is this body of individuals that include legislators, include people with lived experience, people from the community, people from health plans, advocacy groups, that has moved the agenda on a statewide level pretty significantly. They've made sure that funding is available for multiple projects that we've been working on. And, in May, as you know, it's Maternal Mental Health Awareness Month. So we're actually planning a big day at the State House in May where we'll have a couple of talks, and that all of the people that are coming, I think right now it's about 200 people that are registered, will be knocking on legislators' doors, going to door to really promote and talk about perinatal mental health and the impact it has and what we're looking for legislators to do for us. One of them is MCPAP for Moms. It's that psychiatric access program, which has been so pivotal for us in Massachusetts. Again, addressing the workforce issue. So thinking about how we can empower obstetric providers and midwifery to start doing this case management and service provision. Screen, you call up someone who has expertise in perinatal mental health, and you got a consult right there and then. You can start that person's journey on healing and moving towards healing with perinatal mental health disorders. So we love MCPAP for Moms, and we're very grateful for them. The other thing we've been able to do, and again, I think I mentioned this earlier with the speakers, is that our current administration is very interested in perinatal mental health and maternal health in general. So they actually increased our funding for universal screening programs by over $500,000 right? 5, 6, 7, 8. Yep. Universal screening programs at community health centers. And so they have been doing incredible work screening everyone at community health centers. And oh, sorry about that. And they were able to, now this is a little hard. This was 2021. So we were still in the depths of COVID and the impact of it, but 67% were screened during pregnancy, and another 89% were screened during the postpartum period. And that actually happened both in person as well as telehealth visits, which has now gratefully come the norm for us. The other thing the Legislative Commission did was get us funding so that we could draft a perinatal mental health data analysis plan. So remember how I told you it's breaking down somewhere along the way, the data we're collecting from the claims data is just breaking down. The other thing, a part of this is we may have some information. We think we have a good information through PRAMs for postpartum depression, but what about psychosis? What about post-traumatic stress disorder? What about anxiety, bipolar, comorbidities with substance use, obsessive compulsive disorder? So we drafted a plan on how to address this and how we could do a program evaluation for MCPAP for moms. So the methodology is all set out for us, and it's really good. It's available on our website again. There's the link. You can definitely use the methodology. Unfortunately, we've yet to be able to get funding to implement it, but we're still advocating. The other thing we're actually embedding in a lot of our programs across the board is this notion, or this idea, not a notion, but really this idea that all of us need to be taken care of during pregnancy and postpartum, and that thinking about how we can plan ahead for that postpartum period to alleviate some of the stress that may or may not arise. So a lot of people I've known have actually started developing a positive postpartum plan as part of their baby showers. So think about, maybe you have older kids, and when you have a newborn in the house, it's 24/7 newborn. It's just the reality of it. So are there other people that can come and take care of that baby, take care of those older kids and do play dates with them and go out? Is there someone that can come over every day at 5 o'clock and take your dog out for a long walk to a dog park? Is there, can I come over every Friday afternoon at 1? And I'll take care of everything. You just go and do you. You want to get a manicure, you want to take a nap, you want to take whatever it is, I got you covered, and you can count on me on Fridays. So those are the things that we're starting to think about in our home visiting programs, and all of our perinatal mental health work is normalizing that it's okay, that we should be more of taking care of each other. So here's some links to 2 different plans. I'm sure you guys all know this. This is something we embed too, because it's very normal at 3 in the morning and the baby's been crying for hours and you just don't know what to do, and you're going to pull out your hair. Having someone to talk to who just understands is just so powerful, so supportive. And so we're promoting this wherever we can, and hopefully we'll be able to get more languages in the future. But just to be able to normalize, it's okay. It's okay, and you can talk about this. We have a very strong chapter, and I work very closely with them for Postpartum Support International. They're doing a lot of our training for providers, and I'm hoping that we'll be able to fund expansion of this training with this funding I talked about earlier, so that it can become more accessible to individuals across the state. And we actually use their information on a brochure that we've developed. And again, please don't worry about reinventing the wheel. Just kind of look at this. You can go to this website, you can print it out, and just see that this is Maria's story. So remember I told you about Douglas? This is Maria's story. She was also depressed. And then we use the PSI warm line as a resource for people. And so it's not always easy for us to get marketing funds for marketing campaigns and social marketing, but if we can support each other in sharing this information, we're really moving the needle. And so that's me. And I will stop sharing.
Great, Beth. Thank you. And I know when we last heard you present last year, you hadn't had a chance to yet roll out some of the data infrastructure. So it's exciting to see, if I remember correctly, Beth, some of this progress. It's exciting to see some of the numbers.
Yeah.
That's
Thank
great.
you.
Okay, folks, don't be shy. What questions do you have for Beth? We're going to give out like brownie points of some sort. We'll surprise you with some sort of gift to get some questions going here or comments. Well, Beth, why don't we wait? You can stay on for Colorado's presentation, as I understand, right?
Oh, I absolutely want to say, yeah.
Yeah, yeah. Well,
Love
it's
these
always fun
guys.
to like get to talk about each other's programs as well.
Yes.
So, excellent. We'll go ahead and turn it over to Mandy and Jessica. And I'll go ahead and introduce you both. Welcome back. I'm going to start with Jessica. Jessica is the Maternal Mortality Prevention Program Manager, a fitting title for this topic, I think, as a leading cause of maternal mortality. She's been working in the Colorado behavioral health, or in behavioral health since 2004, so quite a long time. She's the perinatal behavioral health specialist and oversees a variety of programs that address maternal mortality prevention. She's also managing the contract from the state public health department with the Colorado Perinatal Quality Collaborative. I think that's going to be really interesting to hear about, Jessica, how you interact and how you're expecting the PQC to address the new AIM bundles around substance use and perhaps maternal mental health or perinatal mental health in that case. I'm going to leave it at that. Jess, I know you've got more that I could share, but we're so glad that you're with us. And Mandy, I'll go ahead and introduce you. Mandy is the Family Adversity and Mortality Prevention Section Manager at the Colorado Department of Public Health and Environment. I think I got that right. Mandy, she provides strategic direction for the program and supports implementation of system and policy change with a focus on equity to improve the well-being of infants and children and caregivers in the state. This includes prioritizing economic mobility, which I think is going to be great to hear about. If you've got just a moment to talk about that, I know several of our fellows, including prior fellows in Pennsylvania, have been looking at economic mobility and maternal mental health. And she's also the Maternal Mortality Prevention Program and Child Fatality Prevention System Manager. We're so glad to have you both, and we'll turn it over to you. Welcome back.
Great, thanks so much. I'm going to pull up my slides here. Where did it go? Oh, is this one? I want to go over to that.
And while we're pulling up the slides, we just want to remind everyone that the slides will be available. I know some of you are asking about those links and you want to get into some of the data that you saw Beth share. We'll make sure that you receive them with a link to the share drive again, just to make them easily accessible. Thanks, Mandy.
Great. Well, thanks, Joy, for having us back, and Stacy for helping coordinate all of this. We really enjoy the opportunity to share some of the work that Colorado has done. So we have been working on improving maternal mental health in our state for a while. You're going to see throughout our presentation, though, it's really not a solo effort. So while Jessica and I are the ones presenting some of this work, it is a, a collective effort of a lot of partners who are really committed to improving maternal mental health in Colorado. And just to plug that Jessica was a fellow back in 2022. So some of the work that is moving forward that she'll share was something that she initiated through the process here. So a quick overview, I'll share a little bit of our history of how our work got integrated into our Title V Maternal and Child Health Grant and our maternal mortality prevention efforts. I'll highlight some of our public awareness campaign work over the years, and also a collaborative that was formed, gosh, almost 5 years ago, or maybe even a little bit more. And then I'm going to pass it over to Jessica, who's going to share a little bit more about how we have intentionally worked to integrate perinatal substance use into our state's efforts. So just a quick timeline. In the mid-2000s, the state health department started working on depression screening as a pilot within a program. It's called Prenatal Plus. And as we approached our 2010 needs assessment, we really wanted to build on that single pilot effort and expand screening and referral more broadly. And so pregnancy-related depression was selected as one of the state's priorities through our MCH needs assessment, which kind of broadened the efforts. And those first few years were really focused on increasing screening and referral with the development of clinical guidelines, a number of trainings. We brought the PSI certificate program to Colorado a number of times. And there was quite a bit of momentum so that it remained a priority in our 2015 needs assessment as well. And with that came the first iteration of our public awareness campaign. Again, we started it off as a pilot. So I think sometimes people can get stuck on thinking public awareness campaigns, require $500,000. And certainly some of our partners in public health get a lot of money for public awareness campaigns. Pregnancy-related depression at the time was not getting a lot of money. And so we had like $15,000 to do some focus groups and hear what people wanted to see in messaging. And then we had $80,000 that we could put towards developing some materials. And then we had a little bit more funding the following year to like 150,000 to grow that. And then we got grant funding to actually have a Spanish language piece. So I just say that to encourage folks in that space of how could we ever do a public awareness campaign? It wasn't because we got a big landfall of a ton of money and we put it all out there. I'll share a little bit more about that in a moment, but in the subsequent years, we've really also added some important infrastructure pieces to our work. So in 2017, the Perinatal Quality Collaborative was established more formally. In 2019, our Maternal Mortality Review Committee was established in statute, and we received funding from the CDC to address maternal mortality. In the most recent needs assessment, the focus of the priority expanded to be social emotional well-being for MCH populations overall. So really integrating that maternal and early childhood framing more broadly. And Jessica will touch on that a bit in a few more minutes. And then our most recent component was adding the State Maternal Health Innovation Grant through HRSA in the fall of 22, which really provides some opportunities to grow and expand our data to action efforts. Our task force members worked on a strategic plan with us in 2023. The data team is starting to look at ways to better understand severe maternal morbidity, including how do we capture some of that maternal mental health data in that, because it's not automatically available in some of our codes, as Beth pointed to. The quality team is looking at where we expand the bundle implementation. So we do implement the substance use disorder patient safety bundle through AIM in Colorado, and what else can we be doing and growing on that. And then the social and structural determinants of health team is really looking at where can we have the most impact on maternal health. Interesting, you pointed to the economic mobility. I think our maternal health folks see alignment there as well. Our economic mobility work has really bridged all populations. It hasn't been focused just on maternal populations in Colorado. And over the last couple of years has had a concerted effort around the tax credits for families. Certainly knowing that families that experience transitions into parenthood are some of the time periods when they most realize the cash flow is impacted. And so knowing that tax credits can really make a difference in that first year postpartum, but certainly for anybody, if they can claim child tax credit or earn income tax credit and get cash back in their pockets. So there's some bridges and connections there. And then last summer, we had our second legislative report. The first when legislation first got established, part of it was that we had to do a report every 3 years. So we have another legislative report that came out, as well as our strategic plan, like I mentioned. And our exciting news is that we got the MCPAP for Moms version in Colorado. So back in 2019, we applied the first time, and we did not get funded, and we were thrilled to get funded in the most recent round of funding. So that program is actually going to sit at the university, which is fantastic. We have the child version of the psychiatry access program already, and this will be able to complement that, and getting ready to kick that off in May. So we're just kind of in the beginning stages of that. Not much to say other than yay, Colorado finally has it. And Jessica, I think if you wouldn't mind maybe sharing some links to our plans and our legislative report in there, so folks have those. But I'll dive just a little bit into the PRD campaign highlights and tell you a little story there. We did started, like I said, back in like 2016. It was part of our action plan for maternal child health at that time. And paralleled that with some of our work around increasing screening and referral still and strengthening those referral networks. So we knew people could hear the messages, but they had to also then have a place to send someone. So we aligned with PSI for that call to action, knowing that they already had a platform that existed we could build onto rather than recreating the wheel. So our campaign was housed within their website and would be a tangible referral resource rather than a one and done campaign that might go away at some point. Our initial campaign focused on pregnant and postpartum people as well as their support system. So really thinking about also the individuals who might notice that something isn't right and be the ones who might reach out, knowing that sometimes moms aren't the first to say, gosh, I'm really struggling. You'll see those images at the top were really more like baby items. We then had additional funding from the Zoma Foundation to expand and do Spanish transcreation. We developed a task force that advised on cultural linguistic transcreation, vetted those with the community. That task force also served as community ambassadors for us, so they would speak with the media or present at conferences for us. We really elevated the need at that time for needing bilingual communications support at the state health department. And I like to think that our campaign was the reason why they eventually hired someone who was both English and Spanish speaking, who could really take some of those media requests in Spanish language as well. We did a refresh of the campaign in 2020 and shifted away from the baby items, the look at the top, to more of the real pictures. We found that our Spanish language campaign actually performed really well. And we think some of the real photos there was part of that. We also increased our racial and ethnic diversity and made the campaign more gender inclusive by really paying attention to the pronouns that we used. Looking forward, we don't currently have the campaign pushing out in media this past year and a half or so, because we've heard from some of the Black and Native American communities that the materials don't fully resonate with them. So we're taking a step back and evaluating what comes next and what would be meaningful for them. But one of the things that really has picked up some interest, and this is credit to Jessica, and she worked with an organization in partnership with our Department of our Office of Behavioral Health over the last year and a half or so to incorporate real stories about pregnancy and parenting and mental health. So similar to Beth's video clip, we also have some videos that were submitted through this partnership. And they have experienced a lot of views. One of them, just pointed out the other day, actually has nearly 500,000 views. And this is in a year where we haven't been doing a ton of promotions. So I'm gonna stop my share and see if I can pull up the video. It's just a quick one, and see if we can get that so you guys can hear it. Screen. I wanted to get out of that. There we go. Okay, let's see how this works.
Within days of giving birth, I knew that something was wrong. Transitioning to motherhood can be so difficult, but there's amazing support out there to help you along your journey. And to all the mothers out there, I'm rooting for you. I was always so afraid.
All right, did that work okay?
Yeah, we heard it for the most part, Mandy. It's great.
There is a whole series of YouTube videos on there. That's just a brief version of one of them, but anyway, just to give a taste of what that looked like.
That's great. And do you guys reuse these like props during Maternal Mental Health Awareness Month? I imagine you push these videos out through your
Yeah, I
social
mean, they're really available for any of our partners who want to use them. They have been pushed out in different like websites. They live on, I would say this past year, we haven't, because we've kind of been in a pause on the campaign. We haven't had as much promotion out there, but they certainly could be used for that sort of thing. And then the last piece I'll share about is just our the Maternal Mental Health Collaborative and Framework. So as I mentioned, a group of folks came together a number of years ago to really think about the broader picture of what we wanted to address in maternal mental health in our state. And so this guiding framework is for all Coloradans, really intentionally support effective collaboration, impactful action, and accelerated progress toward improved maternal health. One of the subgroups focused on programs and services aspect of the work and developed the perinatal continuum of care. It illustrates a wheel of support available for families. And with the person at the center, the tool really illustrates the importance of social connections and informal supports and self-care, but then also mental health and other critical intervention services, including substance use and interpersonal violence, are also included. And while there's an urgent need for these services, the continuum also really demonstrates that perinatal mental health is dependent on so much more. So parent and community support and basic needs and whole person care, focused health services are also really necessary. And then cutting across all of those strategies, of course, is the need for policies and approaches that really lift all families up. The collaborative has also a maternal behavioral health policy work group. So from the state health department side, we don't often engage in policy, but this is a kind of external to the department opportunity where they have had policy advocates come together to advocate for a number of different policy wins over the years. They were part of the initial group that helped get legislation established to have our maternal mortality review committee and statute. They increased depression screening for pregnant and postpartum individuals to include Medicaid reimbursement for pediatric providers and screening in alignment with the Bright Futures guidelines. They helped to expand the Medicaid coverage to 12 months postpartum. We've had that now for, I think it started in July of 2022. And then they also established some continuous funding for what's called the Baby and Youth Survey. It used to be called Healthy Moms, which is a real-time online panel survey for people in the postpartum period through their child's 3rd birthday. That really helps give us a little bit more data than what PRAMs can tell us on the experiences during that full year postpartum. And because research has shown that maternal and infant mental health are linked and maternal mental health outcomes are correlated with child health and development, the policy agenda is broad and also inclusive of issues of infant and early childhood psychosocial health. So they kind of bridge all of those pieces for us. With that, I'm going to pause and hand it over to Jessica to share a little bit about her work.
Thanks, Mandy. So I'm going to talk about some of our initiatives, really looking at the intersection of perinatal mental health and substance use. We know that in Colorado and beyond Colorado that unintentional overdose is a leading cause of maternal mortality, and certainly so much for maternal morbidities as well. We also know it's like one of the most highly stigmatized issues there is. So we've really wanted to kind of bring some attention to this focus so that, moms and birthing people aren't suffering in silence about this. So about 4 years ago, we chose to implement an AIM bundle in Colorado on treating perinatal people with substance use disorders. And, really focused on that universal screening in the labor and delivery setting, outlining best practices for implementing the screening. But we know, that while these safety bundles are great, they're really only as strong as the people implementing them. And particularly with a bundle like this, So much of it really needs to be about culture change on the unit, given all the stigma and bias that exists around perinatal substance use. So we did a lot of things around, implementing checklists, of course, and looking at workflows and building out referral lists, in different communities. So I saw a lot of, talk in the chat about like people don't know where to refer to. So we wanted to have that easy and accessible. But we also really wanted to look at that stigma and bias piece. Mandy, could you go to the next slide? And we heard, from a lot of different, units and providers when we started, like, oh, like we don't have this issue on our units. And what, like, they're either saying like, oh, we don't actually see anyone on our units who are using substances, or if we do, like, there's no stigma and bias here. So, our PQC really wanted to get some data about that and to be able to present back to units. And so kind of developed a survey. And I think they had a pretty creative way of doing it, because it can be hard to say, yes, I have the stigma and bias. Oftentimes people just are not aware of that. So the survey was really aimed at behaviors or attitudes that people see with their coworkers. And that was, I think, an easier way to respond. And people talked about over 50% of the respondents, these were nurses on labor and delivery units, report that their colleagues have negative attitudes towards patients with substance use disorders, and 30% said that their colleagues have negative behaviors. And when asked to describe these behaviors, these were things like being rude to patients, not providing adequate pain medication, not supporting infant bonding, not supporting breastfeeding, stereotyping patients, gossiping about patients, and telling unknowing family members about patient substance use without consent. So I think having this data, like, it's been so helpful to be able to share it back with the units, because kind of when you're faced with this, like, there's this disconnect. You can't say like, oh, this isn't an issue for us. So being able to reflect it back has been huge. And with that, there's been incredible interest in getting, more training and support around this issue. So they developed, our PQC developed a training. It's 1.5 hours. I think, we know there's lots of DEI trainings out there. Sometimes efficacy is questionable around these trainings. But one thing I really love about this training is that it was really developed in partnership with community. And it was developed in partnership with people with lived experience who, helped to design the training, and they're part of running the training. And so it's centered around, it's 1.5 hour training. So it's not, a huge lift, but you have the opportunity in small groups to have some really honest conversations with people with lived experience who are peer navigators and peer supports. And I think, overall, the feedback has been that I think people want to have these conversations in a thoughtful and trauma-informed manner, and they don't always know how. So to be able to have a safe space to kind of say, like, here's how I've been saying this, am I doing it wrong? And like to get feedback on that has been huge. So we've had a ton of demand. One hospital system just signed up. They said, we want to train everyone, including like our security guards. We want all 400 staff trained, because we know that everyone can potentially have an interaction with the birthing person for harm or to detriment. So I think that that's been a really important part of this implementation of the bundle. Next slide. So one of the other things that we've done in Colorado, as we're working on the bundle and working with facilities and listening to community, we really heard that there was tremendous variation in the way that people are using toxicology testing in labor and delivery units. So when I take toxicology testing, I'm not talking about the screening where you're asking patients about their substance use, but the use of, toxicology testing to look for the presence of biological metabolites, from a substance. And we know that there was a lot of inequities in these practices, and that families of color were being tested more often, even though they were not using substances more often. And that this was having implications for families in terms of their trust and willingness to talk to healthcare providers. It was having implications in terms of future involvement with child welfare. So we really wanted to develop some guidance and best practice guidelines for when and how you should be using toxicology testing, because it has a place, but probably a much more limited scope than how it's currently being used. So this was a long process. It probably took us 1.5 years to get to these guidelines. A lot of partnership building, and we had some really hard conversations because people were really coming at it from different perspectives and feeling like these were really important tools for protecting babies. And I think, again, a lot of dialogue, but really coming to the place for like everybody wants the same thing. We want what's best for families. And maybe just some different ideas about how to get there. But I think we landed on these guidelines that we're really proud of, and really get at the fact that toxicology testing, should be used when it would support your clinical management of a patient or an infant. We took some time to really explain the pitfalls of this testing. There were a lot of attitudes sometimes that like, well, when in doubt, just test. And actually, like, these kind of tests can really damage the trust and cause harm between providers and patients. And we took some time to explain that and show the data. Really empowering providers to not test if they don't have concerns. That this is not a fitness of parenting test, really helping everybody to understand what these tests do show and what they do not show. We really focused a lot about the importance of consent and how having consent is always the best practice. And so we are in the implementation phase with these guidelines. They're linked there, so please don't feel the need to reinvent the wheel. Please take them, and we'd love to see them be used more widely. I know some other states are engaging in this work too, I think including Massachusetts, California, but a lot of states, don't have something. I will say implementation's hard. We have some really wonderful champions at one of our major hospital systems who's working on implementing this. But variation across states still exists, and we're working on it. But it's getting that buy-in from all levels is really important with this. So next slide. So another initiative this is actually an initiative that was born out of the fellowship that I did with one of my partners over at our Behavioral Health Administration through it was 2020 Mom then, now the Policy Center. So this was in recognition that we have some really amazing clinicians who are trained in perinatal mental health, and there's such amazing training that comes out of PSI. Granted, I think we all could agree we want the workforce to be even bigger, but recognizing that even among those clinicians who are trained in perinatal mental health, many of them don't feel equipped to have conversations with patients around substance use. And this was really painful for us because knowing that unintentional overdose is a leading cause of death, and the intersection between perinatal mental health and perinatal substance use is a large intersection, we just felt like this was a huge gap in the training of our perinatal mental health clinicians, and also just the workforce at large, who is working with pregnant and parenting people. So we again gathered partners and really thought about what a training could look like, and spent about 1 year developing the content of this training, working with some curriculum content experts at the University of Denver to help us bring this training together. And we're really proud that we hosted an in-person training in 2023 at the health department. We opened it up to 75 people, and like within pretty much a week it was full, and we expanded it to like 100 people, and which just I think speaks to the need for this and the hunger for this content. We've since adapted the training to an online format so we can have greater reach across the state. We've offered it in virtual lunch and learn formats, like 4 1-hour sessions over the lunch hour. We've also done advanced clinical, an advanced half-day clinical training session. So we're really like playing with the different formats. But again, I think, a big hunger for this. We're having conversations with different home visiting programs in the state who are interested in like training the entire home visiting workforce on this. So quite exciting. And but the ultimate hope is, you know, we've also had we've been looping in our partners at PSI Central along the way, and I think they're really excited about this content as well. And you know, we would love the opportunity to have this be part of the PSI and other trainings, you know, so that all maternal mental health clinicians feel like that these are tools that they have. And I think, you know, a big sort of thesis of the training is like, actually, you do have these tools, perinatal mental health clinicians. Like, it's not all that different from what you're doing anyway. And you got this. So next slide. Okay, last slide. This is a busy slide, but I wanted to pull out some examples from the guidance. So even though Colorado was one of the first states to legalize cannabis, we developed some guidance at the time back when it was legalized, but hadn't done a lot with our guidance since about talking to patients about cannabis use during pregnancy and lactation. So it was time to update our guidance. And again, we did, you know, a lot of outreach to our community, and we really heard from the community and from people who are using cannabis, like we were really excited when it was legalized to be able to have conversations with our providers. We thought that like legalization was going to mean that we could go in and have these conversations and not feel judged or stigmatized, and be able to really get good information about like, what are the health risks to me and my baby? And what we were hearing from the community is like, that was not their experience. That they went into care still feeling like they could not be honest about their cannabis use, why they were using cannabis, without feeling judged. And what a lot of people said is that I got information about social consequences, then I might be referred to child welfare, but that's all I got. That, you know, I think really just shut down conversations. So again, we worked really hard with, you know, provider and patient facing with our patient community to develop these guidelines. And really the goal of this, you know, I kind of have it there at the top, but like by sharing fact-based health information in a patient-centered manner throughout the perinatal period, providers can support families in making informed health decisions. And then just a little snippet from some of the talking points, like really framing this, that like, we know everybody wants what's best for their baby. We know people use cannabis during the perinatal timeframe for a variety of reasons, like managing nausea, anxiety, pain, sleep, you know, insomnia. So let's, you know, talk about what we do know. Let's talk about the research and help patients make informed decisions. So, you know, it's a little bit of a shift in framing, I think, in terms of our old guidance, but we really hope it will open up conversations and empower people to make informed choices about what's best for them and their families. So I think that's it. Yep, that's it.
Great. Thanks so much, Jessica. I know there have been some conversations in chat, but like to open it up to some folks. And also just wanted to acknowledge as we tee up our conversation today that Massachusetts, Colorado actually utilized the same guidelines for creating their strategic plan that you all have access to in the Drive. Those guidelines were actually developed. It's the task force convening framework developed from a grant from the Zoma Foundation based in Colorado that also has funded a lot of the work Colorado is doing. So just wanted to call that out, even though there wasn't a legislative request for a task force to be convened. It was still convened voluntarily with leadership from Colorado's Department of Public Health and others, and the same framework was utilized. Just a reminder for our nonprofits in particular, but also to our state agency fellows that are with us today. the sort of the framework or the recipe, as we call it, that we recommend. You might remember in developing your action plans is to start with an awareness resolution in your state. If you're looking at legislative solutions for those who are in agencies, it would mean, going to your governor to ask that your governor would request an awareness resolution declaring May maternal mental health and perhaps substance use disorder awareness month in May, and then working on a task force to develop a state strategic plan. And I know, Beth, you guys have essentially done that as well, but just to remind everyone that we're essentially seeing that happened in Colorado and Massachusetts, more so on the agency side versus, full-blown task force that was called for through legislation. Although, Beth, the Ellen Story Commission was developed through legislation as well. So all that to say, this is exactly what we're suggesting you all do, and those resources are on our website. And Honor, you did ask a question too. I see something in the chat. Feel free to unmute your line too if you feel comfortable, Honor. But I know one of the questions you asked was like, if this were to be housed, all of this work under one agency, where might it sit? I wanted to share my thoughts on that. Is that the legislation that we've drafted that we consider model around forming a task force calls on the state Health and Human Services Agency to commission or set up the task force, even if it were to be anchored in one particular agency. And that's because no one agency really can do this work on their own, as Beth kind of attested to, working with, the state Medicaid agency, behavioral health agency here with Jessica. So it's really no one agency, and it really requires coordination. So for HHS to kind of instruct and provide that sort of framework that agencies should work together, I think is really a good way to start. But I turn it back over to you. It looks like Jessica can talk a little bit, or Mandy, about the California task force, maternal mental health care task force.
I mean, I just added in the chat too, but really our efforts built out of public health, because that's where our maternal child health block grant was. And we're required to do a needs assessment for that population. And so it really got elevated in that pathway. I think it's more recent that we have partnered with our Office of Behavioral Health on the substance use side of things. They do have a gender responsive services program. But at the time that we were doing maternal mental health, that was really like one person doing one program. It was kind of like a prenatal plus-esque. They call it special connections, but it was really like an intervention. I would also say our human services side has often looked at a lot of their solutions, although they think of them as population-based, they're really intervention. They're kind of aiming more towards what's the program we can implement. So we have a new Department of Early Childhood. It used to be under Human Services, but that's where like all of our home visiting programs were. They're like, we can do this through direct programs to individuals, but they were not looking at it from how do we change Medicaid policy to increase screening for depression in pediatric settings. Like that wouldn't have been the frame that the Human Services team would have taken. They would have taken it more as, what's the program we can do for the family. That's where our early intervention sits. That's where our home visitation sits. And that it makes a lot of sense to integrate it there, but it's not the bigger picture. And I saw the question about where did our collaborative get funding. Zoma Foundation was the initial funder for that effort to bring everybody together. They really saw the opportunity for us to broaden outside of public health too, right? Like public health doesn't have to be the center of the spoke. We were one of the spokes on the bigger wheel.
And if all remember the resolution to call for the formation of the task force that's on the shared drive gives an option for the state to fund a task force under an agency like, that HHS would identify, or that it would be a resolution to call on outside philanthropic partners to fund. And that's actually how California got its funding through a resolution. Then the resolution, we took that to private foundations, and two of our largest foundations funded the task force. So it's also a helpful framework if you don't already have a philanthropic partner like Zoma, who was really like leading a lot of the work, championing maternal mental health work in the state at the time. And we don't know of any local philanthropies in any state besides Zoma, to be frank, that are charting the course for maternal mental health, sadly. So Zoma, we've all been very appreciative of. What else do we have? And we invite you, and chat's been fine, but feel free to unmute your mic and ask your questions verbally as well. I wanted to just point out that in chat earlier, for those of you who are interested in some of the comments that Beth had shared around access to the new oral drug treatment, the brand name is Zurzuvae, and I too, Beth, get confused. Is it zuranolone or Zulresso, or which one's the non-brand name? And I get confused, have to refresh my memory often, but I dropped into chat some of the conversation there. Beth mentioned that, there are some concerns about fail first policies. There's also concerns about requiring only psychiatrists to prescribe, which sort of defeats the point, like the whole point is to have more immediate access. And we don't want to refer patients out to wait for 6 weeks to get into a psychiatrist and have to pay out of pocket, right? Because there aren't enough in network, all of those concerns. And OBs really are in a position to be able to prescribe, and psychiatric nurse practitioners, family practitioners, etc. So feel free to take a look at that. We've done an analysis on the large payers and where they sit, and have also done a little bit of review on Medicaid policies too. And it really is, as Beth mentioned, up to the state agency to define coverage. And we've only heard of one state so far that is not putting this on their drug formulary, in which case patients still have access through the SAGE patient support program. SAGE Therapeutics is, from what I hear, has got one of the most robust access programs of any drug company to make sure that everyone has access. So providers should not be afraid to prescribe. We shouldn't be afraid to have conversations about this drug treatment as part of a range of treatment options. Oh yeah, Mandy's talking about foundations who are in early childhood. We should all be pushing them to be thinking about this. I don't think there's enough of them who get it quite yet. So Mandy, that's a good point. And it'll probably take some time to convince them, is what we have found. But we got to start pushing. So very good. And Honor, I think your question might be for each of the public health departments. Like, do you have a state general fund that supports your work? Block grant?
Yeah, that's my question. I'm just thinking through, so for Alabama, we have been trying to get, a kind of one of those, like a creation of a task force or a commission around this, because we have nothing. We're starting from scratch. And so we're trying to figure out what the best route to go is, but we want it to be sustainable when we do, and like start from a really good foundational base. Because right now we don't have anybody who's really looking at maternal mental health from a state entity level, but also just like the ones of us who are on here from Alabama, we are the ones who are looking at maternal mental health. So like, how do we start and create a sustainable state initiative around maternal mental health? And so that's why I'm asking, okay, is it mental health? Is it public health? How does that work? Because we have our ideas, but I'm just diving into those questions to cover my bases as we're thinking through how are we going to build this. And then on top of that, okay, if we build a system where we're going to try to change some Medicaid reimbursement stuff, or even start training for providers to take care of the maternal mental health or maternal population, where does that sustainability come in for our state, so that it's not just, the one day, like the three of us who are from Alabama are not going to be the ones running it. We're going to have to hand it off to someone else as we get older. So like, I'm looking at this sustainability thing, and as much as I'd love to get into the Alabama General Fund, the realities of that are very slim right now, because we're Alabama, we're a poor state. We're always fighting for funding. There's all, and I think every state has the understanding of just limited resources and that kind of thing. So in the end, I'm asking all these questions not because I am asking just like to be like, oh, do y'all really actually have them just to push, but more I'm diving into like crevices that I want to think through before we present, hey, here's the plan for Alabama. Here's our next steps. Because right now, what's going to happen in Alabama is we're not going to get a task force or a commission passed through our legislature. We have 8 days left in our legislative session, and I'm afraid that our resolution for that is not going to pass. So what's our next step? And so that's kind of where I'm going with this. Sorry if that's roundabout, but I'm asking a lot of questions because we're pivoting.
Yeah.
I can answer a little bit there that, we, it did start with our maternal child health block grant, putting a little bit of money towards this. Where we are today is definitely not where we were 15 years ago. When we started with this, it was a small budget. I stole plans from other states. I looked at Oregon's and was like, they look like they're doing cool stuff. Maybe we could do that. Can we do like a little bit of a literature review, or can we like, we pieced together just a few little pieces to start it. And again, kind of built off of a pilot, got that Prenatal Plus program to start the screening. I went back probably 7 or 8 years ago and I was like, hey, do you guys still do screening? And they were like, duh, like, why wouldn't we be? And I was so proud, like, oh, you mean that didn't just disappear when we stopped making it a big thing. So it, the MMRC, we did that for years with about $10,000 and a temporary staff person who came in and looked at cases. And then the legislation came along that that our advocacy partners put through. So don't give up. I guess that's my message to you, is like, even if you don't, like, we did not start with a task force. We're doing a task force because the Maternal Health Innovation Grant requires it. And I would encourage you, if you're not connected, I'm pretty sure Alabama got a state maternal health innovation grant. And
yeah, that's one of the people who's on here with us. And so
okay, I'm like, I was trying to like come up with the names.
Yeah,
so,
no,
okay,
but I'm thinking even past like the 5 years of the innovation grant, like
right.
We can use the money to set something up now, but it needs to be sustainable. And so that's why I'm also like, there needs to be people who work on this and this is their job. So we're also thinking through that and like, how do we maintain their position, whether that be at the PQC, at maternal health or mental health or public health. So anyway, it's more of I'm thinking through longevity and creating the basis that would then set us up for longevity.
Yep. I hear you.
Really, like no
little bit by little bit.
It's all right. Like every state that we see has sort of gotten there in different ways, and sort of baby steps. You just got to get started, and we'll help you with it, Honor. And those are such great questions. No easy answers is what we've seen. Great. Last thing I wanted to just quickly share is that we have, I think Beth and Mandy definitely would be interested in that. You all remember in our February meeting, we shared the new HEDIS screening measures, which are being incorporated likely by CMS as mandatory in the core set for 2016 reporting for Medicaid plans. And then for those plans that are already NCQA, National Committee for Quality Assurance accredited, hopefully before then, this will be mandatory measures. So some of the same foundations, the ZOMA Foundation, the California Healthcare Foundation, funded development of these measures for perinatal mental health screening, which is a whole nother story. It shouldn't be that foundations have to create measures for what matters in our healthcare system, but suffice it to say, really landmark time to have a universal measure that will apply across the board to all states, outside of PRAMs, which is helpful, but this is really looking at like, is screening actually happening? Not just do what patients, recall. follow that. We are going to be doing a report on this soon, and I gave a snapshot at the forum for those of you who attended. We were shocked to see, like excited and shocked to see the latest data set to see which states were highest performers, and wanted to share that Pennsylvania and New Mexico are the top performers within the HEDIS reporting right now, and just something to take a look at. Beth, I imagine this is something that will pique your interest as well, given all the the data work that you're doing. Anyone have questions, comments on that? Yeah, global billing. Yeah, and I think Beth, you kind of touched on some of that as well, with the codes and new codes that were developed, asking providers to submit directly to the public health department. One of the things that we are advocating for when we're talking about maternity care providers, which I think folks know, we really believe should be the home base for screening, even if there's no wrong door, that the bundled rate that they often get paid, the maternity care bundle, it can be problematic in that they would need to bill on a fee-for-service basis, or the bundled rate would need to be increased, or health plans need to put in systems to request medical records, etc. So more to come on all of that, but we'll have a report out soon around what Pennsylvania is doing, and it's mostly payment incentives and incentives that Medicaid, reporting that Medicaid's requiring by health plans, who then require OBs to report on what they're doing. All right. Thank you, Mandy, for joining us today. We're going to move into the last part of our agenda as we wrap up the next 20 minutes here. Wanted to see if
No, Joy, there's no 20 minutes. We're at time.
we're at time.
Yep.
There you go. Well, for those that are here and want to drop into chat, forum feedback, tell us what you thought was great about the forum. You can also send us an email. Anything that you like today, you can drop into chat or send us an email. Graduation set for Wednesday, the 12th. Stacy, I believe you've already sent the calendar holds.
Not yet.
Okay, coming soon.
Yeah, can I just give an update on
Go ahead,
so
please.
we've got 2 date changes that are important for you guys to know, and that those calendar adjustments will be happening. I just wanted to get through this meeting first, so y'all would have a heads up. Our next meeting is going to be May 29th. That's 2 weeks after where we would normally do. Just so we've got conflicts with our guest speaker that day, and gives you guys a little bit more time. That'll be our last content meeting, and then graduation will be the following in June. It'll be June 12th, because June 19th, where we would normally have it, is Juneteenth, so we wanted to recognize that. So 2 important date changes. We'll send those out in the follow-ups. And graduation, we do want you to be inviting your leadership, especially those who wrote your letters of support to get into this program. There will be a calendar invite that'll go out to them that you can share. We'll make sure to get that out for you, and there'll be an RSVP form that we'd like them to fill out too. And all of that will be in the follow-up email that will go out to you after this meeting. So expect that here in the next day or two. But graduation requirements really are kind of the biggest thing. So Joy, I don't know if you want to cover that or if you want me to continue.
No, I think we'll just put this out in email, and we'll be setting up, if you haven't yet set up your one-on-one technical assistance session with us, make sure you get that finalized. We will be sharing, you'll be sharing your action plans during graduation, and we want to do a pre-review of those. So it's just really important to get your one-on-one session scheduled if you haven't yet, and start to really solidify your action plan. And we're here to help. I think we can go ahead and wrap, and sorry, I lost track of time here. It was such a good conversation. Appreciate it. Take care.
Thank you, everybody.